Okay, we're going to talk about intradiscal cellular therapy. So this is not going to be related to injections or gel, and this is a topic that's very near and dear to me as I've worked on most of these. My disclosures, as you can see, I'm a very conflicted individual. So Wu, in the first systematic review came out, and this was published in 2016 in Spine, 6 studies, 74 total patients. This is the world's amalgam of data as it stood until 2 years ago. And so this is where it stood. And of all the cellular therapies, it doesn't work a little bit well, it works a lot of bit well. And on the average, you can see on the force plot, it's 44 points improvement on the VAS score. And 40 points is typically the point we use that a therapy works very well or not. I mean, this is just shot over center field fence into the bottom deck. And 32.2, so this is an oswestry category and a half, more than that slightly. And so this is the average. This is the mean out of these 6 studies, 74 total patients of what we got. And are some of the ongoing clinical trials and some of the completed clinical trials. Take a look at that chart. 5 years ago, there was nothing up here. And now we have a 404 patient double-arm randomized control trial. We have a 218 patient triple randomized control trial. We have a phase 2 trial by Discography. And then we have something that's on the market through the HCTP 361 protocol, the ViaDisc NP. And so we have 4 trials. I'm going to show you the highlights of those top 3s. So this is data from the phase 3 mesoblast trial. And here it is all the way out to 3 years. I'm going to call your attention to a couple of things. Statistically significant improvement in pain, and these are in the range of 48 and 45%. And I'm going to name these in percent rather than the VAS score because we can compare these across trial and across from pre to post. And so these are statistically significant, and you can see the graph as it goes out. Even though the month 36 wasn't stat sig in terms of VAS difference, it maintains a very flat rate, and the curve that you see at the bottom here, this curve is cells plus carrier, which is Hyalin. So this is cells and carrier, cells alone, and placebo. And so pain and function did extremely well in terms of, there we go. And this is functional improvement all the way out to 3 years, statistically significant for cells and carrier. And this is in the range of 62 to 63%. And this is highlighting, so to show you 2 things. Number one, the functional improvement is as good proportionally as the pain improvement, but this is the back pain with a median of just a little bit over between 68 months. So this is between 6 and 7 years, or out to almost 6 years. This is for people who back pain that's less than 6 years, or a little bit between 5 and 6 years or less, they responded proportionally better. And so we have pain overall at about 45%. We have function overall for the people who had lesser duration of back pain all the way out to 63% at 3 years, pain and functional improvement. This is quite a response. So I'm going to talk a little bit about ViaDisc here. ViaDisc is micronized disc material. So you take the end plate. This is donor tissue. This is from the Miami Tissue Bank. And this is bivalve, but this whole thing is taken out as a disc and end plate. And this is micronized to 100 to 300 micron aliquots at 75.75 cc's. And so this has growth factors in it. So not only is it regular disc, it's donor tissue, but this is fibroblastic growth factor, hepatocyte growth factor. So this has stuff in it. If you stain it with the DAPI stain or propydium iodide stain, on the bottom left, you can see cellular material in there. So it has DNA, it has RNA, and this is reconstituted. ViaDisc NP is mixed, the micronized disc material, 0.75 cc's, is mixed with sterile saline, a cc and a half of sterile saline. Regular ViaDisc is mixed with cc.5 of 6 million stem cells. So the stem cells are sorted out to account for their stemness, SSCA4, CD44, CD90, and these are all mixed with the micronized disc material. So the VAST trial, as I mentioned, 218 patient triple arm randomized control trial. This was originally done to assess pain and function and safety. And so these are the first 24 patients that had no persistent significant adverse events. And so in terms of pain and functional improvement, we can kind of compare this to what we've seen in the Mesoblast trial. So these differential points here is this is active allograft, and this is active allograft, which is Viadisc after conservative treatment. So that's why there's 2 points here. This is active allograft supplementation right away, and this is after conservative treatment, and this is saline. So note to self, if you're looking at the pain improvement of saline, is don't use saline as a placebo because the saline is an active treatment. If you were to compare this to basivertebral nerve ablation, something that has great level 1 data across the board, this outperformed basivertebral nerve ablation at 1 year in the SMART trial on a head-to-head comparison. So whether the saline washes out the inflammatory mediators, whether it resets the zeta potential, or whether it hydrates the disc, or probably all 3, this provides good functional improvement. So if you have an intradiscal trial, don't use an active treatment like saline. In terms of pain and function, they're almost identical, right? The last one, so look at the 53 and 66. This is 53 and 65% improvement in function. So the pain and functional improvement are almost identical in the active allograft for the VAST trial. And by comparison, you remember the point improvement goes out to 36.4, and this one is 27.4. The functional improvement is 32.2 for the Wu meta-analysis, and the pain improvement was 44 as compared with 34 and 46. So you can see the VAST trial is on par with the world's amalgam of data. It's exactly the same as what was reported in the systematic analysis by Wu. Most people only test 1 disc, and what's irritating about that for us, the clinicians, is how often do we find 1 single disc that's degenerated and everything else looks perfect, right? Not common at all. It's 4, 5, 5, 1. And this is 2 levels, and one of my favorite things about the VAST trial is they test 1 or 2 discs that are painful. And so if you test up to 2 discs, what happens? Well, it shows in terms of pain and functional improvement, 2 discs actually did a little bit better in terms of treatment. And this is borne out in the Viadisc NP trial, the single-arm, multi-center cohort trial, and this is nice. And this, I'm going to show you a comparison of all of these. And so Rexlemestrocel is the name of the cell for Mesoblast in the Cascade trial. So pain improvement, 48% and 61.9%. And this is for the patients that had low back pain less than 68 months, and these are for all patients. It's pretty comparable to the active allograft of 53 and 66%. And so the ODI, and this is from the phase 2, the reason I report this from the phase 2 and not the phase 3 is I could not extract the ODI data out of the phase 3. I was part of the phase 3, and I still don't have access to that data. And so this is, even though it's not very much, I mean, it's only 32.7%, this was statistically significant at 1 year as compared with the ODI of 27.4 and 36.4 for the VAST. So you can see these are pretty comparable. If anything, the Viadisc may have an edge over Mesoblast, even though Rexlemestrocel performed exceedingly well. This might have a little edge. So let's compare the results of the phase 2 for Discgenics, because Discgenics not only performed well, but it was a phase 2, so they had 3 million cells. They had 9 million cells. They had carrier alone. They had 9 million cells plus carrier. So this had a dose response curve. So I'm showing you the data for 9 million cells that clearly separated out. So how many cells is necessary to augment the disc? 6 million to 9 million at least, maybe more. This is 6 million cells. That's 9 million cells. And look at the pain and functional improvement in this. This is at a year and a half. This at a year, 63% and 59% in terms of pain improvement. And this is compared with at a year, 53%, 2 years, 44%, 3 years, 54%. So fairly comparable. ODI improvement of 26 and 31. The ODI improvement goes up. So as this goes along, the patients actually get better from 1 year to 1.5 years. And this is 27, 23, and then 27 again at 3 years. And some of these included patients that were retreated. So one of the things we can say about these, not only in terms of pain and functional improvement, are they optimal, they're pretty durable. So we have 3-year data out for Viadisc and Rexlemestrocel for the Vivex product and the Mesoblast product. And we have 1.5 year data for Discogenics, albeit phase 2 trial. And here's one I wanted to show you in terms of a dose response curve. And this is, the dose response curve is kind of a pharmaceutical term we apply because we test different doses looking for the most optimal response. And here in blue, this is a dose response curve for the 9 million cells plus carrier. So all the way across the board, this does well in terms of pain, function, quality of life. I've mentioned pain and function to you, but this is the EQ5D is also something that demonstrates improvement. So for Viadisc NP, kind of quick snapshot of this, you may have to evert your eyes. This is not published yet, but this is the data. So on roughly 70 to 75% of the people, they have a 60% improvement in pain and function across the board, if you follow that. So out of everybody that comes through, about 3/4 of your patients are responders to this. If they're a responder, they'll have an average improvement in pain and function of 60% moving forward. And this is a single-armed, multi-center cohort trial. So bottom line is we have 2 large trials that demonstrated prominent and durable change all the way out to 3 years. We have on its heels a phase 2 trial, and all of these 3 products are going to have multiple phase 3 trials. So Vivex, Mesoblast, and Discogenics will be running allogeneic long-term phase 3 trials upcoming this fall or winter. And the pain and functional improvement is right along the lines with the pain and functional improvement that's been reported previously in the WU systematic review and analysis. The nucleus pulposus cell line that's mentioned in Discogenics, this is an allogeneic nucleus pulposus cell. The cells demonstrated in the Mesoblast Rexlemestrocel is an allogeneic grown cell line, is propagated and grown, and the cells in Vivex are harvested from the hypoxic bone marrow region adjacent to the disc, and these are donor cells. So they're all allogeneic, but they all have very different origins, but they appear to perform about the same. And finally, we have the Viadisc NP, and this is on the market. This is the 361 product that you can use in your patients, and this has become absolutely essential for me because you have somebody that's young. I have a 24-year-old fitness instructor that comes in after having a 4-wheeler accident a few years back. She's got mild degenerative disc disease at 2-3, 3-4, and absolutely perfect health, but just can't go because of the back pain. And so without something like Viadisc, we have nothing, and that's a travesty. But the same person I'm describing treated her; she's still doing great. She stays in contact, still doing great. So this is a good example of something that's absolutely essential. And with that, I'm just going to finish up showing you a few just examples of pre and post cellular therapy. So we have modic 1 changes here. 1 month later, no modic 1 change. Interesting. So we have disc protrusion in back. It's almost as a character of an extrusion going up and down. 6 months later, pulls in, smaller. We have the start of increased signal within the disc. And right here, I'm showing the VAS score pre and post and the ODI pre and post, so dramatic clinical improvement as well. Increased signal from pre to post. Interesting. So I never see this with any other therapy. Also increased signal. Also, we have an end plate change right there. So one of the things that we notice is the end plate changes either go away or they appear. And you can get something that if you get a reactivity to whatever you inject, you get a biologic flare. And this is something that, just be aware of that exists. And if you get scared, send a text message with a photo and ask, and I'll send you some back and show you what it is. And we've got a whole series of these. But look at the VAS, 62 to 0, 40 to 4. So whatever that is, not painful. And we see 1 to 2 disc. We see a shoring up, tightening of the annulus and back. This person was treated with 2 levels. And so what is the answer? When do we use this? Well, what we don't get is from this all the way to that. You can take an ovine model, a sheep model, and take it from completely degenerated to new. Looks not degenerated at all. The difference between us and sheep is we don't walk on 4 legs, and we don't degenerate, but we get something close to what I just showed you. But it doesn't really appear. So lack of change, should you get increased signal and make yourself better, feel better? No. Lack of change doesn't say anything. What is the presence of increased signal or an improvement of the disc herniation? Still don't know at this point. But it appears that the change, the morphology change, is really not related to change in pain and functional quality of life improvement. But you won't expect the top. You probably can expect something like this. As we move on, we get it from moderately degenerated to a little bit improved. More importantly, we get pain and functional improvement, get the person that typically is affected, which is on the average about 40 to 42 years old, back to life and back to work and back to enjoyment. With that, I will say thank you very much. Questions, comments?
Hey, Doug.
Yeah, Ryan.
Great presentation.
Thank you.
Couple questions. So how often have you found that you needed to redose a person? Because I know on a couple of the folks, you said that they had to be redosed after a certain amount of time. And then at most, how many levels do you treat together?
So, I really like 2 levels at a time. I like 2 levels because it's common and we have data. So this, to be able to just treat 1 level, I'm not a fan, and I don't want to see more phase 3 trials just treating 1 level, because what happens is the advantage that Vibex has, and full disclosure here, I wrote the Vibex trial protocol, and I wanted it at 2 levels, and that's something I really insisted on. And I have to say that most people disagreed with that because too many confounding variables, et cetera. The talk track. But look, if it comes out and it's on the indications for use, you can only do 1 level at a time. I mean, so you have a guy that's 62 years old with degenerating changes in bottom 3 discs. I don't want to have to treat, bring him back, treat, bring him back. So 2 levels I think is has a lot of utility. And the VAST trial shows that was appropriate. 2 levels did slightly better than 1 level. The Viadisc NP trial, the 2 levels did slightly worse. But we can suffice it to say it's about the same. The redosing happens at about 30% of the patients in the VAST trial got redosed, about 30%. And it appears, so 1 and 3, the results are durable, but 1 and 3 had enough of a flare and return to of their previous symptoms that they needed to be redosed. Out of those 30%, the pain and functional improvement, the decline in discomfort and pain was about the same as the original dose. So it kind of puts them back on that curve. And, the indications for redosing was just return of symptoms. It had nothing to do with imaging. Good questions. Yeah, Dan.
Oh, thank you. What's the role of provocative discography prior to treating with cellular therapy? Is that gone by the wayside? You think there's some utility still in doing that?
So I think discography is essential, absolutely essential. You'll find that majority of my colleagues will disagree with that. But let me give you a scenario. So you come in, the patient comes in with 3 discs, and we commonly will eject all 3. Pain goes to a 0. So which ones do we treat? Well, we don't know. If they come in with a 4-5 and 5-1 disc, and we inject those, and the pain goes to a 0, we know for sure that we can, at most, have to treat those 2 levels, and that's it. So just like identification of patients that have basivertebral nerve ablation, you have to have modic type 1 or 2 changes. This is best treated with modified Fuhrman grades 3 through 7 or 3 through 6 and moderate amount of disc degeneration. So we know that when we know just based on this, we can get it to the point where, yeah, I can identify on imaging the person with sustained hip flexion, degenerative changes in MRI, midline pain. We're already at a 94% positive predictive value that they have a painful disc. But to really be sure you're treating the right levels, there's nothing like, and I never do provocative discography in isolation. Never. I haven't done it in 15 years, and I won't do it again because it's brutal, as you know. So I inject it. I inject the medication, 2 cc's of a mixture of dexamethasone and preservative-free lidocaine. Tell me if this is the same as your typical pain. I don't use manometry. I don't care. I'm not doing provocative. I just want to get some provocation response. Yes, same as my typical pain. And then you can CT them after you, and before I do this, I inject about half a cc of contrast. You can CT them and see there's no contrast outside of the disc. Pain goes from a 7 or 8 to a 0. So how sure are you that that disc is painful? Well, 100% sure, right? And then the other thing that it does is the patient walks out. There's nothing that says, I trust what this guy is doing, like a 7 to a 0. So the person walks out of there and they're like, first time in 10 years. I mean, 5 years and 8 months less for the Cascade trial was identified as short-term back pain. That's a long time to have back pain, even in the short-term group. So this is something that you can be sure, you can really identify it. So I think it's always verify what you do before you do it. And the downside about doing provocative discography and anesthetic with the concoction, the mixture that I said, is that there's a lot of these patients don't come back. I mean, they get well and they stay well. They feel pretty good. So there's a role for therapeutic. We just there's a paper I'm working on with Anthony Giuffrida. We're trying to get published. It's in the process that shows really great durable pain and functional improvement with just the therapeutic disc injections. Yes.
Anecdotally, when you do the biodisc, when do patients generally say that they feel the difference?
So that's a really good question. The timeline on that is, and especially after what I just described, patient walks out, they're at a 0. They feel great. I tell them, like, look, this is not going to be the same. I'm not going to inject you. You're not going to go from an 8 to a 0 walking out of here. When I put this material in your back, and for those of you who haven't done it, I want you to listen to this because this is different. You're going to feel full. You have a strained sensation. Some patients describe their legs being feeling separated from their torso, or they have a very full feeling, or they walk out of there with minimal to moderate amount of pain. And this is different. This is a different sensation, because we don't inject therapeutic things into the disc with the patient mostly awake, just under MAC or completely awake. And so they'll have a different sensation. I said, you will start to feel better starting in month 1. And that's about how it is. The curve goes down like this, or TU goes down like this. And they start to feel better at about month 1. And you won't be as good as you will be until month 6. And so the flat part of the curve doesn't get down until about month 6. But it does appear to be durable. I mean, this, in terms of lasting, this appears to last a good long time. Questions, comments? Yeah, Ron.
So I have a handful of cases coming up in the next couple weeks, but all my patients are 65 and above. How are you getting these approved in the 42, 40, 45, 50-year-old group?
So who's your Medicare carrier? West Virginia? Is it WPS? NPS?
NPS.
So I'll look that up. I'll have an answer for you. So Ryan practices in West Virginia. So our Medicare carrier Novitas approves it straight away for 65 and above. Noridian jurisdictions E and F, the treatment nihilists don't approve it. Neither does NGS or WPS. All the other MACs, those are the only 3, all the other 4 approve it. So let me look up, see what area, what MAC you have, and I'll let you know. But otherwise, you don't need to have approval. You just they will approve that based on the category. And I'll have more information on the Category 3 code. 0627 and 28 is the T code on this. Viadisc is a Category 3 code. Questions, comments? Yeah, Neil.
So the CT scan is part of protocol. You could just as easily do it with fluoroscopy.
Yeah, so that, right. So the T code has CT. So the first two codes are fluoro. The second two codes are CT guided. Yeah, I don't think I've ever used CT to inject a disc. But I did that to appease the radiologists. The radiologists love CT. Is there any radiologists in here? God, I'm the only one, per usual. But no, I did that. They really wanted CT guidance in there. I'm like, okay. So don't use CT. Use fluoro. It's easy. It's fast, cheap, ubiquitous, better. Just my advice. Questions, comments? Okay. We're going to turn it over to Dr. Naidu, who's going to demonstrate basivertebral nerve ablation. And we have talked about basivertebral nerve ablation. As he's getting ready, let me tell you what my typical talk track is for a patient. I'm using an amalgam of the data. The SMART trial, the Intercept, and the single-arm cohort trial says this. It says that for basivertebral nerve ablation, you have about a 75% response rate. For those that are responders, on the average, the pain reduction is 75%, and it appears to be durable or permanent. And this is an amalgam of the data on basivertebral nerve ablation that will be expanded upon by Dr. Naidu.
Great segue.